to the Congress for inviting me back. I was last here in 2020 when there was a nasty virus on the way. I'm sure we all remember that. Thankfully that's gone, and it's lovely and very kind of you to invite me to talk to you about subchondroplasty. So I'm from Birmingham, in the middle of the United Kingdom. That's us there, several big hospitals all amalgamated together. And Birmingham's famous for a lot of things. Especially now, it's half Egyptian-owned Premiership football club, Aston Villa, for whom I do matchday trauma cover. I'd like to talk to you about subchondroplasty, and I think the last talk I very much enjoyed, but it does show where a lot of our focus is. It's on the nice, smooth, shiny stuff, the actual articular cartilage, and I think it's very important that we spend some time thinking about truly what we are concerned about. It's not just the articular cartilage, it's the underlying subchondral bone. Now, of course, we know that the osteochondral unit has these three layers: the articular cartilage, the subchondral bone, and the anchoring layer, that calcified cartilage. We know the role of cartilage to transfer load-bearing weight over the joint, allowing for normal articulation. And we know where it all comes from. I'm sure we all remember this origin of the cartilage anlag that gradually gets replaced with bone as the blood vessels come in. And we know that we're left with cartilage at the ends. And it's important to really realize that this comes from that interzone. Now, the interzone is condensed mesenchymal cells that results in the articular cartilage and the underlying subchondral bone, this common origin. So structurally intimately related, embryonically very importantly related. This is a study looking at the development of the knee in a rat. Now, you can see that we're talking about the very same area, that interzone, that starts all as one. And gradually, as it cavitates, this area becomes separated. All of those little yellow cells indicated there, all forming the osteochondral unit. And we've already heard, actually, very beautifully about some of the advances in articular cartilage management, focusing on reducing the pain. But we know there's no nociceptors in the articular cartilage. It's in the bone. That's where the blood vessels are. And we know that when we're repairing chondral injuries, we know what our aim is. And I just put it to you that actually our aim should be to repair the subchondral bone for the same reason. Because we know that injuries of any of these three layers can progress to arthritis in a very similar way. So what is a bone marrow lesion? Well, I'm sure we all have terms that we use to describe it to our patients, and I often use the term bone bruise or bone edema. It's not actually accurate. We're talking about increased bone remodeling areas. We're talking about these specific pathologies: vascular structure abnormalities, the fatty marrow, necrosis, and bone marrow fibrosis. Actually, there's not much edema. So what's the issue with these bone marrow lesions? Well, we know that with this bone remodeling, we get loss of subchondral bone support, and then we get lesions that don't resolve and go on to degrade. And if you have one, you can be 9 times more likely to need a knee replacement in 3 years. They're serious. So we know that focal damage to the osteochondral unit initiates this cascade of repair, but there's a process going on called crosstalk. So crosstalk isn't just the mechanical relationship that we've spoken about, where the change in the elastic modulus can affect the loading, but it's also about the biochemical relationship. So normally there's perfusion of molecules and cytokines deep within that osteochondral unit. But arthritis changes this. It changes the diffusion potential across that area. And you can find that coming from the bone will be some signaling molecules that will potentiate the degeneration. Now, the truth is also true in the opposite way, whereby molecules can communicate into the bone. So we've got this two-way communication going on, this crosstalk. So, cartilage surgery is sexy. We all like doing it. We all get great pictures from it. I enjoy doing it. But I think just as with Egyptian building and in the English rugby line out there, you can see that often the foundation is more important than what's going on at the top. So, subchondroplasty then. Well, this is a technique, a very simple technique, and I invite you all to consider it as part of your armamentarium. We're talking about injectable calcium phosphate for this particular technique that one can inject into the bone, normally under arthroscopic and fluoroscopic assistance. The results are good, as long as we choose our patients properly. There was a couple of papers here that are worth looking at. This one by Chatterjee, 2015, was actually a paper saying it doesn't work very well. They claimed they had 55% success. and a lot of grade 3 or 4 cartilage lesions. But actually, 21 out of 22 of the patients in their study improved. Perhaps not quite such a failure as they were painting. But I think what's interesting looking at these series is that a lot of them include grade 3 and grade 4 degeneration. In a systematic review by Nairn in 2020, a lot of patients here, and I'm sure you'd agree, some fairly impressive scores, but only at 12-month follow-up. So this is our experience from my unit, where we looked at the site, the MOAC score, which is a MRI referencing score, and we looked at those pre- and post-op outcomes. So the MOAC score is really refining the bone marrow lesions, the cartilage and the meniscal pathology, divides the knees into regions and gives you a single grade for each region. And these are the typical things that are looked at, looking at the size of the bone marrow lesion, the percent that's marrow versus the percent that's cystic, the size of the articular cartilage loss, and the meniscal extrusion, such as measured there. So this is our numbers, and you can see that actually for the vast majority of our patients, we're talking about a medial lesion, often associated with some meniscal extrusion. Okay, so grade 1, 2 and 3 meniscal extrusion quite common. But actually most of these, we saw that when we're talking about the cystic content with regard to the MOAC score, 3 is no cyst. So a lot of these had no cystic change. So a lot of them therefore a pure bone marrow lesion rather than bone marrow plus cystic change. And these are our results. Mean 32-month follow-up, minimum 12-month follow-up. We're going from 7 to 2 on the VAS, we're going from 23 to 40 on the modified Oxford, from 37 to 81 on the lysome. We wanted to look at patients that had done particularly well. I defined particularly well as having a VAS score improvement of 6+, Oxford 20+, lysome 50+. And we haven't really got the number of patients to give you some true statistical analysis, but the trends that I saw were that generally if the patient had a low Kellgren-Lawrence grade X-ray, generally if they had lower percentage of cyst, and generally if they'd had post-meniscectomy pain, the results were very rewarding. So 3 patients had had subchondroplasty after a meniscectomy. They then had that residual bone marrow lesion that I'm sure a lot of us have seen on the medial tibial plateau, particularly where there's been a flipped meniscus displaced fragment. They all did very well. 1 patient had a scope just before I came back to do the subchondroplasty. He did very well. 12 patients in total had a partial meniscectomy. In 11, we were also doing some edge stabilization. And I use a product called N-Stride quite frequently, which is autologous protein, like a white cell-rich PRP, but the people that make it hate me saying that. But that is some confounding factors for you to consider. So who is suitable? Well, the evidence would suggest we're talking about excluding those with 8 degrees plus of coronal malalignment, probably talking more about those people having HTOs. I don't think it's a case where we should be doing, or we shouldn't be doing this kind of technique for people with severe arthritis. I don't think bone cysts are suitable, and I do wonder whether we might be talking about subchondroplasty at the same time as treating meniscus lesions. So it's not injectable bone graft. This was something I had to educate myself on. This was a large cyst that actually did really well. This was a large cyst that didn't do very well. And that's my calcium phosphate stuck there in the tibia. Felt a bit silly. I bone grafted it with bone from the pelvis. Patient did very well. There's then the question of, well, maybe we should be addressing both sides of the lesion. If there's some chondral failure and some subchondral failure, should we be addressing both? And I think really there is some potential here too, although it hasn't yet been adequately explored. So my suggestions about how we should go ahead with this, well, this is a patient that I saw literally this week. This was 3 months ago. This is now, her pain's gone. Clearly they need a period of conservative management. If you're having difficult access, it does involve passing a cannula, as you can see down here. That's passed across the knee. In this case, I did it from the same side, and we've got quite a lot of extrusion down here of the acuphyll. So I would recommend that for a lot of these where it's more peripheral, come from the other side. I do think as well that where you're not quite sure where exactly that lesion is in that 3D visuospatial assessment, putting a K-wire in first just to give yourself, if you like, a clear shot to see where you'd want to go is quite helpful. You then need to leave the K-wire in, otherwise the acuphyll that you inject in will just squirt back out through the hole you've just created. So leave the K-wire in until it's all set. It takes about 5 to 7 minutes for it to fully set. The risks, well, we haven't had any complications. If you get extrusion of your subchondroplasty acuphyll, then you must wash it out. It's clearly going to be an irritant. But generally, you can see where that's happened. You should always scope the knee after you've injected to make sure none's extruded through any little increased lacuna diffusion areas. In the literature, we have got a report of 7 cases of AVN following subchondroplasty. It doesn't seem to compromise knee replacement, and osteomyelitis has been reported, though thankfully none in our series. When we're talking about the alternatives, different companies are now looking at different things that should be injected into that lesion. Should it be calcium phosphate? Should it be PRP? Should it be something else? Well, actually, if you look at, I think it's Arthrex that are looking at PRP injections, their results are pretty good, actually. The literature would suggest about the same as this, with some fairly substantial improvements. And I don't have any personal experience of the last 2 techniques with BMC or that canine study, I'm afraid. So generally, we are talking about good improvements for all those alternative techniques. Thank you very much.